Hello, everybody. Welcome to the Research into Practice webinar series. We're really grateful that you've all made time to be here today, and we're excited to hear from the Psychosis Research Unit. So my name is Emma Wilson. I am the Communications and Engagement Officer for Research and Innovation at GMMH. We have a different research unit presenting each month about the research that they're doing in their specialist areas and how that might impact you as clinicians and what it means for you in your care. So our speakers today are from the Psychosis Research Unit, who we call PRU. So without further ado, I will pass over to the both of you.
Thank you all for being here today. I want to, before we start today, just acknowledge that this is a very serious and personal topic for many people who've experienced a serious mental health condition. And I want to just therefore acknowledge that we could have lived experience in this room today. So if that's relevant for you, please do take good care of yourself. Please, if you need to take a break, step away and look after yourselves. And whilst this is an incredibly serious topic, I hope that Rory and I can leave you on a message of hope about how we can end stigma together. So we'll start off with thinking about awareness of the problem. So what is the context? What is stigma and discrimination in relation to serious mental health conditions? And what are the problems and challenges associated with that for people with lived experience? We'll move then on to thinking about stigma conversations. So what we're going to look at there is how can we hold conversations about stigma or discrimination in relation to mental health? And how can we foster those conversations and understand the impacts for the individual? We'll then move on to ending stigma together and take a really good look at some of the latest literature on how we can end stigma. And then we'll finally end with discussions, questions and answers. Okay. So let's start off with the question of what is stigma? One of the earliest definitions in relation to mental health stigma and discrimination comes from Irving Goffman in 1963, and it's still incredibly relevant today, which is why I've included it on the slide. So Irving Goffman defines stigma as the association of some negative attribute with a sign in another person or group of people that distinguishes that group of people. That might be something visible on meeting a person, or it might be something that is more invisible in terms of, for example, a physical health or a mental health condition label. So what we've got here is on the right hand side, you share a similar attribute in terms of, for example, that could be in this case a serious mental health condition label. And what stigma and discrimination does, if we have a look at the group of people on the left hand side that are there in blue, is that label then becomes associated with stereotypes. So stereotypes are best thought of really as inaccurate, faulty knowledge structures that group of people there in blue would have about that group of people there in yellow based on them having that label. And stereotypes of serious mental health conditions are often very pernicious. Stereotypes, for example, of people being unreliable or untrustworthy or dangerous in some way. Now, what stereotyping leads to is often prejudicial emotions towards that other group. So, for example, maybe mistrust or feelings of fear. And we know that that then leads to unfair, unjust treatment of other people based on their membership of that group there. And a really important point for me for this slide is to remember that stigma is based on bias, grouping people together and not seeing the individual, and it's based on inaccuracies and myths that are perpetuated. We can go one further though and have a think about understanding stigma in relation to the stigma system. So if I just load all this up, so we have there in the middle the individual with a serious mental health condition, and the light blue colour on the outside represents the society, the structures and institutions that person is living within. So for example, living within being exposed to the media, institutions, funding bodies for healthcare or research. And we know it operates on that structural level through others such as the media, through funding for healthcare. If we go to that next layer, that kind of darker blue layer, we're all operating, each and every one of us, within community groups, workplace, healthcare, exposure to police, education, mental health care settings, or religious groups. And we know from interview data with people who've experienced a serious mental health condition that in addition to being exposed to messages about mental health conditions from structures like the media, people might also be experiencing discrimination or stigma from that community group. The lives of friends and family, so thinking about stigma operating within neighbours, work colleagues, family in terms of friends, partners, siblings. For example, through interview data, we know that sometimes people might be exposed to stigma from neighbours if they've had, for example, a hospitalisation and an ambulance has been called and neighbours have seen the ambulance arriving, or from very close friends or family members. And then not forgetting the individual at the heart of that. This person is operating within all those structures, so it's highly understandable that that individual perceives stigma to be present. Let's take, for example, if you see a newspaper headline about, for example, if there's been a homicide and they're attaching that to the label of a serious mental health condition. And we know that people internalise stigma. So what is internalised stigma? Internalised stigma is internalising some of those stereotypes into how you view yourself. Maybe thoughts such as, maybe I'm not good enough, maybe I'm not capable, maybe I shouldn't apply for that job or go for that relationship. Internalised stigma is also having very difficult decisions to face around disclosing your mental health condition. You might need to disclose it to get access to help or support or reasonable adjustments in the workplace. So there can be very difficult dilemmas set up for people around disclosure. Internalised stigma is also emotional responses that the individual has to operating within this structure, this system. So, for example, it might be feelings of embarrassment or feelings of shame, or indeed feelings of fear yourself for being exposed to discrimination and being treated unfairly. And as we'll come on to see, we know that all of this can have an impact on the individual's psychological well-being. For example, impacts on experiences of psychosis, impact on personal recovery goals. So this stigma system, this is drawn directly from interview data with people who have lived experience of psychosis from the study done by Lisa Wood, Rory and myself and Tony Morrison a few years ago now. It's bringing together all of that interview data, but this is very representative across serious mental health conditions. It's really important, if we just go back to this slide and see that person in the middle, one aspect of their identity might be their experiences of a mental health condition. But it's really important to remember that there's many aspects to who we are as individuals, as humans. And we know that there's an interconnected nature of social categorisations of race, class, gender, that all create overlapping and interdependent systems of discrimination. And that comes from some of the really early work by Susie Crenshaw in 1989. So stigma is obviously and understandably much more harmful when it coincides with other social adversities, for example, migration, poverty, gender, ethnic minority status, or sexual minority status. And this model here comes from the work done by Ray et al. And colleagues in 2020. In the reference list, so you can find this paper, which really again just brings to mind that we need to see the full person, and we need to understand that somebody might not only be operating within systems which are discriminatory to mental health conditions, but also discriminatory to other aspects of their identity. And that's really important, because that means then that we can see the full person and understand the full impact for that individual. So moving on, how often does stigma occur, and what is its impact? So what we have here is some data that we've drawn, some research data that's been drawn from a really large international survey. This one was conducted with people who have lived experience of psychosis. And what they did is that they asked over 1,000 people who were living internationally to provide information on any experiences of discrimination that they'd had. And what we can see here is that rates of discrimination were high for this group of people. So 47% reporting experiencing discrimination in making or keeping friends, 43% reported discrimination from family members, just around about a third in relation to finding or keeping work, and just shy of a third in relation to intimate relationships. Now, whenever I present this information and this data, I think it's really important that I just highlight that this is much bigger than numbers. If I was to sit back myself and think about what is important in my life, and if I was to encourage you to think about what's important in your life, I think we'd all probably connect on things like having meaningful activity, friends, family being very important to us as human beings. So this goes beyond the numbers, and I think, you know, it's really, really important to remember the individual that is experiencing discrimination in relation to these areas of life. Thinking about other serious mental health conditions, we know that these figures are similar in relation to people who've experienced bipolar disorder. And whilst unfortunately there's comparatively less research in relation to emotional unstable personality disorder or borderline personality disorder, some work that one of our colleagues at the Psychosis research unit, Dagmar Makara, Rory and myself have been doing shows that for people with EUPD, discrimination is occurring quite often within the mental health system from mental health care staff, and quite often from within the physical health care system as well. So, for example, things such as diagnostic overshadowing, where people's physical health concerns aren't attended to because they're being viewed through the lens or the label of a serious mental health condition. So what kind of impact does this have for individuals? Well, again, I'll just draw your attention to another large-scale study that's been done. Again, internationally, this one again was done with people with lived experience of psychosis. And what they found is that 49%, so almost 70% of people reported high levels of perceived stigma. And just over 40% were experiencing moderate to high levels of internalised stigma. And when we look at that data a little bit more closely, the most common aspects of internalised stigma that people were reporting was a sense of alienation, so a strong sense of feeling very different or very unwelcome within society, and also reporting higher levels of social withdrawal. So maybe making the decision not to pursue or go after things socially that were important to them because of concerns about stigma. A really important model, which again we've referenced, comes from the work done by Patrick Corrigan, John Larson and Nicholas Ruresh, and this is called the Why-Try model. And what this does is it explains some of the impact that internalised stigma has for people with a serious mental health condition. Internalised stigma can lead to eroded self-esteem, so how you view yourself, confidence that you might have, and also eroded self-efficacy, so the sense that which you trust yourself to make good decisions. And what that can lead to is impacting on people making the decision to, why try to pursue that important life goal, maybe around education or employment, because there's a high chance that I'm going to be treated unfairly based on the experiences I have in terms of mental health. And there's very strong evidence that internalised stigma is consistently and significantly associated with higher levels of depression, anxiety, and suicidal ideation, and also associated with lower levels of personal recovery, so personal goals, sense of empowerment, and a sense of self-efficacy. So that's that kind of trust that you have in yourself in making decisions. So unsurprisingly, the Lancet, which I think is the oldest medical journal and is a very important, prominent journal internationally in the medical health community, the Lancet commissioned a really important piece of work published in 2022 that was brought together by Graham Thornycroft and many other people, many of whom have lived experience. And this was one of the key statements from the Lancet Commission. So they said it's time to end all forms of stigma and discrimination against people with mental health conditions for whom there's double jeopardy. The impact of the primary condition and the severe consequences of stigma Indeed, many people describe stigma as being worse than the condition itself. And this piece of work brought together much of the stigma literature that's been conducted over the past 20 years internationally. This was one of the concluding statements that they made. I'd really encourage you all to, we'll summarise some of the Lancet Commission today, but I'd really encourage you all to read it because it's got a wealth of information about what we can all do to end stigma, and it's got a wealth of lived experience voice in different multimedia formats as well. I'm going to end my bit there for the moment and just pass you across to Rory, who's going to talk to you about how we can hold conversations about stigma and what the lived experience of stigma looks like through people's voice and reports. Across to you, Rory.
Okay, thank you, Melissa. I mean, Melissa's kind of drawn out the picture of what stigma is and how to understand it so well. Nonetheless, it's so important that we have done work over the years, and many of our colleagues in research have done work listening to people with experience of serious mental health difficulties. Our focus especially is on psychosis, but Melissa also mentioned our colleague Dagmar, who's looked at stigma associated with borderline personality disorder, or EUPD. I think when we speak to people and we conduct what are called qualitative research studies, so interview studies, typically one-to-one private conversations, we hear such rich, detailed, often moving, often very, very sad feedback when we ask people about how it has been to experience stigma associated with mental health difficulties. I think in the interests of time, perhaps there won't be time for me to read through each of these quotes, but perhaps if you just let your eye glide across the screen and see the kind of things that people are talking about. To give you a bit of direction, the first 4 quotes at the top, they all come from individuals who had experience of psychosis or a diagnosis of psychosis, telling us something about what the impact that has been for them. The bottom 2 quotes are from people who had been given diagnoses of BPD or EUPD. The first quote is talking about the impact on friendships or trying to grow friendships, and how fear of the other person's perception can get in the way of that. And then the person used the word scared of somebody finding out that they were taking a mental health medication. The second quote is highlighting something Melissa's already touched on, and that's the extremely negative perception, the overstatement of risk and fear that's there in the mass media, unfortunately, still to this degree, where particular diagnostic labels like schizophrenia, in this case, are associated so automatically and so completely with violence. And so people out there in the community who are no harm to anybody and will never pose a risk to anybody are labelled with exactly the same fear, and those around them are subject to that. Somebody feeling like a second-class citizen, that's terrible. Nobody should feel like that because of what's happened to them in their life. The fourth person highlighting that there's a problem with association, with social connectedness that can break down, and that's different between mental and physical health. It shouldn't be different. Melissa talked about diagnostic overshadowing that happens. That's highlighted in the quote on the bottom right. Very, very serious. Really serious physical health conditions can be overlooked or missed because of a healthcare professional's assumption about mental health, shadowing that or kind of somebody misinterpreting physical health problem. Needless to say, or perhaps it is important to say, those few quotes are the absolute small tip of the iceberg. There's so much rich information and feedback we've been given from people's direct experience. So please do explore those qualitative research studies if you'd like to, or get in touch with myself if you'd like me to send kind of full research articles of that type. Moving towards perhaps a more hopeful stance, having understood what stigma is, how it impacts people from those kinds of research studies we've carried out. One of the really important steps moving towards something more positive is developing an interview measure of stigma. And this was created, the first author, the lead was Lisa Wood, Melissa's already mentioned, and we each played a part in the work that went into this. I'll start from the kind of headline in the top of the screen, which is most important to frame this, that talking about mental health and stigma can foster a space for people to share if they have experienced stigma and to create opportunities for support. So talking about stigma, really, really important, but people don't often get that opportunity. We understand that services and all of our mental health staff colleagues are incredibly pressured. They may not feel like there's time to focus on stigma in particular, but it can be such an important feature of what's happening for somebody that it really is worth trying to find some time, if you can, to ask somebody if that's a feature of their difficulties. Moving back to the SIMS measure, it's an interview measure, meaning we use it in research and we use it to record rates, levels, frequency of experienced stigma in a very, very rich and, again, qualitative way. So rather than asking somebody solely for numerical answers to questions, it's much more of a rich conversation. It's offered empathically without the kind of researcher having any assumptions, timing it appropriately, making sure it's comfortable for the person, and asking the kind of questions that you can see that way in a very, very person-centered way. Very, very gentle interview format. And the measure also looks to explore any barriers that might be getting in the way of somebody's personal recovery goals, especially associated with stigma, and to identify at the positive side of that same coin goals that they'd like to get to when they've moved beyond those barriers. And also, of course, very important to understand the impact of stigma at the very individual personal level. So again, moving away from a purely numerical rating to getting a richer sense of a kind of summary of that person's lived experience of stigma. How has it made you feel about yourself? How does it affect you day to day, and so on? And then jumping forward, let's call it a giant leap, not a small step, but a giant leap to really doing something about this. Peer support. Peer support, we believe, will be a very, very effective and very meaningful way to address stigma directly with people. Because so much of what stigma is, it's about that break in social connectedness and not feeling that you're able to relate to other people or vice versa. Peer support, by definition, is bridging that gap naturally, automatically. It's bringing personal experience of these difficulties into that conversation where both people speaking in a peer support dynamic understand that they've both been there. A study kind of currently being led by our colleague Alison Brunitsky has found from our previous smaller Let's Talk One trial that the intervention delivered by peer support workers was found really, really valuable for those people who took part, particularly in those terms of shared experience and having supportive, non-hierarchical interactions, often seen as distinct from people's experiences of standard clinical services. Again, in the interest of time, I should probably not read the full quote there, but you could perhaps let your eye glance across what Sam was saying and their positive experience about meeting with the peer support worker. Likewise with Tracy, and feeling really valuable that the peer support worker was comfortable to share their experiences, which might have been the first time Tracy has had that. And as Matilda said, it's not something we get to hear about very often in normal public conversations. Melissa?
Thanks, Rory. I think that's over to me now. Okay. So Rory has really, really well covered there. There is a hopeful message, and there are lots of things that we can do to think about ending stigma together. We wanted to share some of those key highlights with you, one of which being peer support. But just for a moment, I'll bring you back to the Lancet Commission on Ending Stigma Together and go through some of the kind of key highlights from the Lancet Commission. One of the first things that I really want to highlight is that, as the Lancet point out, people with lived experience of mental health conditions should have that equal seat at the table for being able to make the change within health and social care, within work spheres, within policymakers and media organisations. And that principle of lived experience, of nothing about us without us, is really key and central to addressing stigma and discrimination together. It's simply not going to work without the experience of people who have experienced a serious mental health condition having that equal seat at the table. Just a point on that though, let's not forget that stigma and discrimination sets up difficult dynamics around to share, to disclose, or to not share and disclose your own experiences. So we need to foster environments that are safe for people to be able to share their experiences and have that equal seat at the table. The Lancet Commission really, really highlights that contact-based approaches, so approaches that bring people with lived experience into the department, the area, the work that's being done, is essentially key to making change. We need real stories from people with lived experience, and as Rory's just highlighted, peer support is one route that. Education can also be very helpful. It's not quite as helpful as contact-based approaches, but it very much has its place. And that makes so much sense, because if we think about, again, what I said at the start, what stigma is, it's faulty, it's bias, it's myth, and education that's simple, accurate, can really counter myths and stereotypes. If you remember at the start, we talked about that stigma system and the policies that we have, the structures that we have, the laws that we have, and advocacy is really, really important for working at that system level. And also for addressing media responsibility. And it might feel like there's nothing you can do in relation to media, but there absolutely is. And some examples, for example, the Psychosis research unit, myself and a group of colleagues, when we saw very stigmatizing, very stereotyping an event that was taking place in the Northwest, we lobbied that event and wrote a letter and had many people who were both people with lived experience, academics, researchers, clinicians sign that letter. So we can try and all work together to address that media responsibility. And as we said, there's a really strong emerging evidence base for peer support for supporting people with internalised or self-stigma. And just to highlight that message of hope, whilst we know that rates of discrimination are high, and whilst we know that the rates of internalised stigma are high, there is also research that suggests that stigma resistance is present very much for people with serious mental health conditions. So one study found that almost 50% of people with psychosis reported moderate to high levels of stigma resistance. And that is gold, and that is lived experience that is key to the stigma change that we need to know about. So thinking about some education strategies and thinking about challenging the legitimacy of stereotypes, I just want to share some mental health advocates who are out there doing incredible work, who really challenge the legitimacy of stigma and discrimination. I'm just going to take you around the screen very briefly. So in the top right hand corner, we've got Adam Deacon. He's an award-winning actor and writer, mental health advocate, and Bipolar UK ambassador. And Adam himself has experienced bipolar disorder and has done a lot of work speaking out to support other people, particularly young men, and offers a very strong message of resilience and hope and community connection. Below Adam, we have David Harewood, who some of you may recognise, again, award-winning actor, who has written a book and had a TV documentary where he talks about his experience with the psychosis. Next to David Harewood, we've got now Professor Ahmed Hankia, Professor of Psychiatry based between London, Canada and London, UK. Professor Ahmed Hankia describes himself as a person living with a mental health condition and a survivor. And that is, of course, nothing to be ashamed about. And his book, Breakthrough, A Story of Hope and Resilience and Mental Health Recovery, talks not only about his experiences of mental health stigma, but also of racism and Islamophobia as well. Then in the bottom corner, next to Ahmed, we have Shocker, born as Kenneth Erahon, award-winning rapper, grime artist. And in 2010, he was named by the BBC as on the Hot for 2010 list because of his talent. And he's also spoken out about his experiences of paranoid schizophrenia. And Shocker has said, I do it for the kid like me who could use this information at a young age. I never knew anyone or I've seen anyone that has been sectioned. He's also done a TED Talk and he's in a book which I will show you in a moment. And then above Shocker, we've got Johnny Benjamin, who's now Johnny Benjamin MBE, and he's a mental health advocate and campaigner and produced a documentary called Stranger on the Bridge with Rethink. And then next to Johnny, we have, who's now Professor Eleanor Longdon, international speaker who also has a TED Talk, who's spoken out about her experiences of hearing voices. So lots of wonderful, incredible examples that really unpick the legitimacy of stereotypes and offer a message, a really important message of hope. There's also some incredible written resources out there. And I should just say, I've provided Emma with a list of resources that's going to be circulated to you all after after this talk today. Just a few key examples: The Book of Hope by Johnny Benjamin and Britt Pfluffer, which is 101 stories of overcoming adversity in relation to mental health and addressing stigma. Lots and lots of different examples, and as I've just mentioned, shockers in there. David Harewood's book, Maybe I Don't Belong Here. Living with Voices, 50 Stories of Recovery from Roman Escher. Eleanor Longdon has also written a book, Learning from the Voices in My Head, and a really, really important booklet that comes actually from our very own Manchester Early Intervention service users, Our Lives, Our Voices, which are short stories of people's experiences of psychosis, hope and recovery, that is also going to be circulated to you. So education can be really, really helpful and powerful, and we hope that's just a few examples of resources that you, either yourself, if you have lived experience, will find helpful, or if you're working with somebody with lived experience, will find helpful for addressing stigma. Before I move back to Rory, we touched on peer support as a really powerful approach for addressing the impact of stigma and discrimination. One of our homegrown studies at the Psychosis Research Unit was the Let's Talk 1 study. And just a little bit of context, Let's Talk 1 was developed and grounded in the psychological models of stigma that I presented earlier to you today, particularly thinking about internalised stigma and some of those difficult dilemmas around disclosure processes, which we've touched on. It has lived experience at the heart of it. So Let's Talk was developed from the Honest, Open and Proud programme, which was developed by Professor Patrick Corrigan and John Larson over in the United States of America. Pat himself has lived experience of a serious mental health condition, and the work to develop the Honest, Open, Proud programme has all come from community-based participatory research with people with lived experience. And Let's Talk has focused on reducing internalised stigma whilst helping people navigate the complex decision-making processes around mental health decisions. And it's all delivered by peer support workers who will utilise their own lived experience to help support people to work out their own empowered decisions in relation to talking about their mental health experiences, and also addresses shame and fear, which is often around stigma and discrimination. Just very briefly, we did Let's Talk 1 here at GMMH, so thank you to anybody on the webinar today who referred to the study or took part in it even. And we had 70 participants from here at GMMH and also some from North East London, 10 from those from North East London who took part. And 35 of them received peer support with us, and there was a really high uptake of the intervention. So 88% of people who were allocated to receive the peer support on Let's Talk took up that option. And there was really strong indicators. Well, I should just say it's a smaller scale study. It wasn't designed to answer the question around how effective is the intervention. But we got really strong indicators when we analysed the data to suggest that the intervention had large effects for internalised stigma and smaller but still significant effects for personal recovery. So good news is we're doing this study on a larger scale to actually answer that question of is it effective, and we're going to be running it here at GMMH as one of the lead sites, so we wanted to make you all aware of that. And if you're interested, you can read the results of the Let's Talk 1 paper in Psychological Medicine, and we've included the reference there. It's open access, so everyone can read it. Okay, I'm going to stop there and pass you over to Rory for the final few slides.
Yeah, thank you, Melissa. I think in the interest of time, I will simply headline this. We wanted to include a bit of a statement just to emphasise that lived experience or personal experience of psychosis was involved, as Melissa has already said, at every stage of the development of the first smaller Let's Talk trial. You can see the arrow indicating a kind of start to finish approach there at every stage of adapting this previous HOP approach coming from America for the UK setting. People with lived experience were involved in the team, integrated from day one and throughout, helped develop or kind of refine the peer support work. We had peer support specialists leading supervision for the staff on the trial through to qualitative interviews with both participants who took part and the peer support workers who delivered it, all undertaken and analysed by people with lived experience. So it's an exceptionally rich degree of lived experience involvement that has kind of contributed to this project. And very, very quickly, I won't read all of these through, but please feel free to ask us for the slides. But just to give you a kind of a sample of the kind of changes, adaptations that were made to this project and the peer support, especially thanks to that lived experience learning that we were able to gain, making the intervention and the materials more accessible as much as possible, for the intervention to create a safe space for those people to take part, for all the reasons we've kind of talked through already about how stigma impacts people's ability for social connectedness and so on, but also in the delivery of the intervention to balance structure and flexibility, found to be really, really important to help people work through it at the kind of individualized level in the way that works best for them, both the individual taking part and the peer worker they're working with. And back to you, Melissa.
Thank you, Rory. So yeah, to conclude, stigma and discrimination of mental health conditions does occur frequently, unfortunately, and as we've presented, unfortunately can also be a barrier to personal recovery goals. Ending stigma and reducing the harmful effects is possible if we all work together. Lived experience, co-production, contact-based approaches are all central, and that's evidence-based to addressing stigma. And the evidence base for peer support is growing, and is suggestive that it can have an impact for reducing some of the harmful effects of stigma and discrimination, and that there's really good positive effects emerging there. And that brings us to the end of the talk, so thank you so much. I believe we're on to questions and answers next, Emma, if that's correct.
Yes, thank you so much both. That was really, really helpful, and thank you for sharing your experiences of Let's Talk as well, and I'm excited to see Let's Talk too. I'll just ask one or two questions. We're getting a lot of thank yous coming through, which is very lovely. Thank you all. I thought this is a really interesting question we received earlier. What role do healthcare professionals play in unintentionally perpetuating stigma, and how can this be addressed?
Thanks, Emma.
The question, sorry, was about how might they unintentionally?
Yes, unintentionally perpetuating it, healthcare workers.
I think there's probably a multitude of answers to that, but one thing or a couple of things might be, it's kind of a controversial topic, but we're kind of medicalizing. I think there can be absolutely clear benefits to offering a medicalized diagnosis and medicalized treatment approaches for people experiencing really serious mental health difficulties, including hospitalization. But for all of the benefits that those can give, they come with trade-offs, they come with costs. So, for example, the idea that a serious mental health difficulty is fundamentally a physical problem that could only be treated in a medicalized way, unfortunately, almost certainly for many people, reinforces the idea that there is something wrong fundamentally at the physical level. And when we think there's something physically wrong with us and there doesn't seem to be a cure, that gives us the very clear impression that we're stuck with this for life. And not just that, but that I'm saying we because I'm somebody with experience of psychosis spectrum difficulties, but that we are fundamentally different. When I was in college, we were still reading textbooks with abnormal psychology, and psychosis was featured there. So we were told, I was in that audience in a lecture hall while going through something that was emerging to be psychosis, being told that I was abnormal. So that's the really sharp and negative end of a medicalized approach, is that it gives the idea that there is something fundamentally different going on. Other approaches don't really have that same negative impact. So a more humanistic approach, a kind of trauma-informed approach would be part of that picture, is telling somebody that you're fundamentally the same as everybody else, but that you've experienced an extreme level of trauma, stress, effective migration, and so on. Very, very quick final caveat to that. I absolutely get that there are, and understand that there are forms and experiences of psychosis that are physiologically derived, that might kind of come in the context of delirium and so on. But those are the minority. For most people, it's really not that clear cut.
Yeah, thanks, Rory. I think you make such an important point there, Rory. And I too sat through the psychology lectures on abnormal psychology, and I think it underpins a concerning message about how we perceive people. I guess there's research data to kind of back up what you're saying there, Rory. Actually, so if we look only purely at biogenetic perspectives of serious mental health conditions, what the research and that's been used actually as an anti-stigma strategy, is just purely promoting a biogenetic perspective. If we only have that perspective in mind and we only promote that within society, and we don't also include trauma-informed approaches as well, what we can find is, whilst you can see a slight reduction in blame of the individual, what we do see is an increase in perceiving individuals with serious mental health conditions to be dangerous and unpredictable. And what that's about is almost that very deterministic view, like Rory, you were saying there about that kind of abnormal psychology, that viewing of somebody as deterministically flawed, something inherent within their biology. And we know that that can then increase that perception of dangerousness and unpredictability, which are, I think, two of the most pernicious types of stereotypes that people might be exposed to. So actually, although that was used as an anti-stigma campaign strategy, it was in Germany, they got that data coming through, which was highly concerning and counterintuitive to what the anti-stigma strategy was trying to do. So I think having that global view and understanding, really seeing the person and how their experiences are arising in the different life contexts, which might include the biology, but also including trauma-informed approaches and understanding the social world is really important.
I would kick myself if I didn't just quickly add in the word humanize. Humanize is the answer to so many of these questions around stigma. Simple as that, really.
Yeah, and just to build on that, Rory, so a study that was done by Sarah Clements and colleagues, which unfortunately their expert panel wasn't people with lived experience, and it should have been, but their expert panel was other researchers in mental health stigma and discrimination. They were asking what are some of the most important messages for addressing stigma and discrimination. The top one was just what you said, Rory: see the person. And I think that's a really important take home from today.
Thank you both. Another one that we received was, how does stigma of psychosis impact occupational performance? I know we've touched on it a bit.
Yeah, I mean, I guess it's probably a large area to cover in what short period of time that I've got. Undoubtedly, the literature speaks to stigma and discrimination having an impact for people in relation to the workplace. And I think one of the kind of key challenges that people often face, which is one of the areas that we look at on Let's Talk actually, is that really difficult decision-making dilemma that's set up around what to share and how much to share about your mental health experiences, because people should have reasonable adjustments under the Equality Act, but that unfortunately then puts the onus on the individual to have to make that decision about what they feel comfortable sharing in order to have access to reasonable adjustments. So I think there's a real challenge there within the workplace for the individual in terms of thinking about what am I comfortable with sharing, and also that difficult dilemma then with having access to those really important reasonable adjustments that everybody should have. And if you look at the Lancet Commission, workplace is one of the key areas that they want to address, and that's everything from understanding within the work department around mental health conditions education, but also the policies and procedures that we have and the training that managers have. And conversely, we know that actually if people have access to employment, there's often lower levels of internalized stigma. So if we can get that right, that can have a really positive impact for people. But it's a really important big topic. I want to make sure, Rory, you've got some time to comment on that. I think it's a really important question.
Yeah, like you said, Melissa, it's very, very broad. Emma, just to check, was the question about the impact of psychosis on occupational performance or stigma on occupational performance?
Stigma on occupational performance.
Yeah, I think Melissa's probably largely covered it. Yeah, it's a big question. Impact on the individual who's subject to that stigma. Well, it can put people off work, for example. It could Melissa touched on the concept of why try. If somebody fears that they're not going to be accepted, that it's not going to be comfortable, that they're going to be seen as different or othered in a workplace, they might not apply for jobs in the first place. It's not a really, it's a difficult thing for anyone to do. And other people face different forms of discrimination when it comes to seeking employment. This is one of them. So at the very first hurdle, the stigma or the fear of stigma in the workplace can put somebody off even trying. Once in there, if somebody's gained a role, even a voluntary role, yeah, that experience will be subject to all the things Melissa's talked about. People's performance can be interpreted through the lens of stigma. A manager or a colleague can judge a little bit of poor performance or a bad day through that lens of, well, it's because of this mental health diagnosis, when it might not be. It might be a bad day, like everybody has a bad day, so it can overshadow things in that way.
And I think the only final thing that I would add is just in terms of the reference list that we've provided, there's a paper by Hajiza, which has got some really concrete examples of things that can be done in the workplace, open access, so I'd encourage you to have a look at it. And obviously individual placement support workers, IPS workers that we should have within across GMMH can be really, really helpful and supportive for people who are looking to return to work and navigating some of these things. So yeah, they're just the two other things that I'd add.
Thank you. I think the person who asked the question is one of our colleagues, Michael, who's a occupational therapist in the community. So he said that his role is why he asked the question, and he knows that stigma is definitely a factor in transitioning back into work. So thank you, Michael, for adding some extra background to that as well.
Really important question.
Yeah, there's so many questions we could ask about this, and I know we only put this in for 45 minutes, so we're already running over. We will end it there. I'm really grateful for those of you who continued on to listen to us today. Thank you again, Melissa and Rory, so much for making time for this and doing this presentation. When is Let's Talk To due to be recruiting? Have we got a kind of vague idea yet?
Yeah, we have. So we'll start recruiting in November this year, and the study will be open to people who have lived experience of psychosis, who are also reporting concerns about stigma and the impact that has on those decisions about talking about their mental health experiences. So we're going to be around for the next couple of years in GMMH, looking for people to take part in the study. So if anybody's interested in that, please get in touch with me. But if anybody's interested in any of the resources, any of the papers, really, really open to people contacting me.
Fantastic. For the ease of that, AskAboutResearch@gmmh.nhs.uk is our kind of go-to mailbox. So if you have any questions, whether that's wanting to refer someone, have any other follow-up questions about this presentation, you'd like access to different resources, or you'd like to get involved in taking part in research in a certain way, please do email us there at AskAboutResearch, and we can forward you on and connect you with Melissa, Rory, or some of our other colleagues. This is a shameless little plug for our website, which is gmmh.nhs.uk/research-innovation. We have a load of resources on there, including a library of our active studies. So that's studies that are currently recruiting or are just about to finish. And they're in a total different, range of conditions and types of interventions. It could be pharmaceutical, it could be therapy-led, it could be interviews. There's lots of different things going on and lots of different people who can take part in that. You can search by keyword, you can search by condition. So if you have a few minutes and you'd like to browse and see what we're up to, and maybe if you could get involved in any of that, please do visit that. And we have our social media channels as well, where we publicise some of our published articles that have GMMH linked authors to it, any upcoming events and other studies that we are recruiting as well. So keep your eyes out. You'll probably hear about Let's Talk To from us in the next few months. Thank you again, Melissa and Rory, and thank you everyone for your time this afternoon. I hope you have a great rest of your week. Bye.
Thanks so much, everyone. Bye.
Thank you.